So you've seen the patient, the testing is in, and then, so how do the data from recent trials influence your management in the adjuvant scenario? So Jason, tell us a little bit about the recent article in Journal Clinical Oncology by Axel Hausschild. It was really the long-term follow-up of COMBI-AD. I think they're out to something like 4 years by now, so very impressive follow-up. So what does it tell you?
So when we get a patient in the adjuvant setting for stage 3, obviously we have options for both immunotherapy and targeted therapy. And the targeted therapy options are based on the COMBI-AD study, which was initially presented a couple of years ago, which really showed an outstanding benefit for relapse-free survival. And now we're starting to see further updates for the longer-term follow-up of those patients. And so I think they're quite impressive results. Looking out at 3 years, we see relapse-free survival rates somewhere in the 60% range, 55, 60%, and overall survival still trending out that far. You know, our big question is what percentage of these patients will truly be cured with targeted therapy? There's sort of a hypothesis that we're suppressing things. Are we truly eliminating those cells? And these publications, a previous presentation, they make a case that in fact there is a subset of patients who are truly being cured out with this longer-term follow-up.
So that's the so-called cure rate model,
Exactly.
That's what you're referring to?
Yeah, so projecting out, looking at the slope of these curves of both the combination dabrafenib, trametinib versus the placebos, we're starting to see this absolute benefit be stable between the curves, somewhere in the mid-50s versus high 30s sort of range, really suggesting there is, you know, a 10% or higher absolute cure rate there. And I think that that's quite powerful when we think about adjuvant therapy, these patients who really are at high risk of recurrence.
Yeah, so there will be a few other abstracts, not necessarily looking at long-term results of adjuvant studies. The nice thing about COMBI-AD is it was started before any of the other nivolumab or pembrolizumab or other studies, so it probably has the longest follow-up, which is important. But I think Mario Mandla is going to present a poster probably this afternoon where he's going to talk about immune-related adverse events and association, or I should say lack thereof, of the immune-related adverse events with relapse-free survival in CheckMate 238, which was the nivolumab versus ipilimumab adjuvant study. And it interests me that even though the urban legend is that the immune-related adverse events may be associated with outcome, at least in this study, there really wasn't much of a potent association of any of the different types of immune-related adverse events, and this is now 900 patients. No association with relapse-free survival that was statistically significant. Yet I hear, I did not see it, but I hear that there was a poster in the DT immunology section where Lex Egermont described some similar data from the less mature Keynote 054 study where he did think there was some association of IRAEs or immune-related adverse events with relapse-free survival. So it'll be yet another argument over how do you reconcile those data. But at the end of the day, when patients ask me, well, gee, if I don't get side effects, does that mean it's not working? I tell them, no, I wouldn't think that way. I mean, do you get that question?
Yes, and I think this all dates back to the beginning of checkpoint blockade, and obviously, you know, just with ipilimumab alone, there's sort of this is it or is it not a side effect related, and I think we can't confidently say that it is.
Yeah, to me it's weak.
You know, the patients will either do well or do not. I don't think this is the thing we should focus on.
Ryan, do you get that answer also?
Yeah, I get that question asked quite frequently, and I agree. I think there may be some toxicities that seemingly are associated with benefit, like vitiligo, which makes sense. We're treating melanoma, and vitiligo is the immune system's attack on benign melanocytes. So I think that probably does associate with benefit, but colitis or pneumonitis or hepatitis, I think it's weak at best.
It's really interesting that you kind of discuss whether more toxic treatments should be more effective, because actually, you know, at this ASCO, the results from E1609 are going to be presented where actually you are using, that's a large randomized multi-center trial that accrued over 1,600 patients in the US that compared ipilimumab to what was the only standard of care at the time, which was high-dose interferon. And interestingly, in that study, they actually had 2 different arms with 2 different doses of ipilimumab, where it was 3 milligram per kilogram for one arm and then 10 milligram per kilogram for one arm. So speak of things that can cause more toxicity. Ipilimumab at 10 milligrams actually had a grade 3/4 rate of adverse events that was almost 50%. Whereas the 3 milligrams only had, you know, 37%. I mean, it's still significant, a large number, but a lot less than the 10 milligram. And yet, when you looked at efficacy, and that's what this is being reported at this particular ASCO, the higher dose wasn't associated with a higher efficacy against interferon.
In fact, it almost looked as if the lower dose was a little bit better. I mean, did I misinterpret those data?
No, you're right on. In fact, the hazard ratio for the 3 milligram was actually 0.78, whereas for the 10 milligrams, it was actually 0.82. So it kind of looked a little, kind of less effective. I mean, you can't really directly compare because they weren't actually compared against each other. They were all beating up interferon. The interesting part, actually, that I find from this particular trial as well is that this was an overall survival reported for this particular study. So there was enough of a follow-up that there was some overall survival data indicating that ipilimumab may be more effective than high-dose interferon in affecting the overall survival. But again, it's a modest improvement from my perspective, and I think now that we have nivolumab having clearly been superior to ipilimumab in this setting, even to the 10 milligram dose in CheckMate 238, I think this particular study doesn't directly impact practice as well.
Okay, and Ryan, tell us about Keynote-054,
Yeah.
because that's the most recent adjuvant study with data, again, relapse-free survival, no overall survival yet, but tell us, that was recently published.
It was, and it actually built upon another question that I'm asked frequently is, do I need to be treated now, or can I be treated when I progress or relapse, or if I relapse? And it's a reasonable question. If a patient has a 50% chance of relapse, that means they have a 50% chance of being cured with Dr. Sondak's or his colleague's surgery. And so the questions that are being asked in Keynote-054 are twofold. One, is giving pembrolizumab better than giving placebo in the post-operative setting for stage 3 melanoma? And what's clear from a relapse-free survival standpoint is it absolutely is. It's associated with a much lower relapse rate, a hazard ratio of 0.54. So about half of patients will relapse when they're treated with pembrolizumab versus placebo. However, the second question that's being asked in the study is, at time of relapse, patients are offered the chance to have pembrolizumab and will be followed further. And so it becomes does pembrolizumab reduce relapse? Yes. So the first question has been answered. And the second question is, does getting pembrolizumab right after surgery or monitoring closely, active surveillance, and then progression or relapse, and then being treated with pembrolizumab, does that actually impact overall survival? Does it really matter? And it's an interesting question. It's the only trial that's been designed to answer that question. And so what I tell my patients is, I don't know.
Would you feel comfortable as a patient going on that sort of trial with the idea of, well, you can get pembrolizumab now, or maybe you can get it later when you relapse?
I mean, at the time, the trial was perfectly okay. The standard of care was arguably placebo or observation.
Understood.
And so at this day and age, I think it does allow us to have conversations with patients that we think might have a bit more risk, say a patient with an autoimmune condition but a high-risk melanoma. Should I treat that person now and risk their autoimmune toxicity flare now, or do I follow them very closely, and then if they are a recurrent patient, do I then treat?
Yeah.
And
So
for earlier stage disease, that exact question, treat now everybody versus selectively treating only those who recur, is going to be an extraordinarily important question.
And along those lines, I mean, I think clinical trials are starting to explore that early stage 2 disease, which we've historically considered lower risk, but in fact, actually, there is substantial risk there. So these questions will become quite pressing. Just to summarize quickly, though, I think it's really important to sort of really clearly state this, that I think the days of interferon and ipilimumab are really now past in terms of stage 3 disease. It really should only be PD-1 antibodies or BRAF use in that setting. And we still sometimes get referrals of patients who are started on some of these things because they are listed in compendium guidelines. But I really want to emphasize that that's really not a reasonable standard of care at this point.